You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for August 26, 2022. This week, early rhythm control in AFib, coronary disease and TAVI, 3 early trials from the ESC meeting, along with a preview of upcoming trials from ESC. The first topic today is early rhythm control. So Circulation has published yet another sub-study of the EAST-AF NET4 trial of early rhythm control versus standard of care in patients who had AFib for less than a year. This study considered 2 subgroups, those with high-risk stroke features and those without. Now, to do this, the authors dichotomized the enrolled patients to a group with a CHA2DS2-VASc score of 4 or greater, or those CHA2DS2-VASc less than 4. Now, before I tell you about the sub-study, let's quickly review EAST-AF NET. EAST-AF had about 2,800 patients randomized in 135 centers in Europe. The trial compared early rhythm control to standard care, which was basically rate control, and they measured a primary outcome of CV death, stroke, heart failure, or ACS. And over the 5-year period, EAST-AF found a statistically significant 21% reduction in this primary endpoint. And many of my colleagues in EP felt relieved that the negative results for rhythm control in the 20-year-old AFFIRM trial have finally been reversed. And since we tend to be proponents of ablation, and ablation is a rhythm control strategy, EAST-AF NET has provided tailwinds to the early AF ablation therapeutic fashion. Now, I respect and admire many of the EAST-AF authors, but I've not been this enthusiastic about the results for many reasons, but here is the big one. Go to Figure 3 in the EAST-AF supplement in the New England paper. At 2 years, 60% of the rate control arm was in sinus rhythm versus 80% of the early rhythm control. Do you really think that 20% difference in sinus rhythm in a cohort of patients of whom 90% were on oral anticoagulants can drive this much benefit in heart outcomes? If you're like me and you don't believe that antiarrhythmic drugs and AF ablation do reduce heart outcomes, then you have to explain why this would be. Why was there so much reduction in outcomes with this little difference in rhythm? I think EAST-AF is one of the best examples of performance bias there is, because the early rhythm control had as its goal maintenance of sinus rhythm. Patients were instructed to transmit a patient-operated single-lead ECG twice per week and when symptomatic. So this surely led to more care of this group. And that more care is likely what drove the results. Now, there was also a fair amount of missing data in EAST-AF, and there was a 3-fold higher adverse event rate in the early rhythm control arm. That is, if you don't double count primary efficacy events in the adverse event table. Now finally, EAST-AF should not be held up as a reason to do early ablation because less than 1 in 5 patients in the early rhythm control had ablation. Most of the early rhythm control in EAST-AF was antiarrhythmic drugs. All right, now to the subgroup analysis from Circulation. The main finding of that paper was that early rhythm control reduced the primary endpoint, CV death, stroke, heart failure, and ACS, by a statistically significant 36% in the group with a high CHA2DS2-VASc score greater than 4, but early rhythm control did not have any notable effect for those with CHA2DS2-VASc less than 4. Here the hazard ratio was right at 0.98. When you go look at the major drivers of this benefit in the high-risk group, you find that stroke was more than halved with early rhythm control. CV death was also substantially lower. Now, to me, this stroke signal is super strange. Remember that more than 90% of the total cohort was on oral anticoagulation, and there was only that 20% difference at sinus rhythm at 2 years. So either this signal is statistical noise, which is always possible in subgroups because trials are powered for the overall analysis. And when you start slicing things up into smaller groups, whether or not it's pre-specified, you introduce noise. Go ahead here and Google Richard Peto ISIS-2 trial astrological sign. But let's say it isn't noise. Let's say it's real. I think this strengthens the case for performance bias. Patients with higher disease complexity would be more likely to benefit from more interactions with the health field. Okay, second topic, coronary disease and TAVI. So patients with aortic stenosis are often older, and older patients with AS often have coronary disease. In the days before TAVI, a surgeon who replaced the aortic valve would also bypass these lesions, but TAVI has changed this calculus. Recall that patients with complex coronary disease were excluded from the TAVI trials. And that is fine. That's not bad because TAVI trials aim to compare strategies to treat a valve issue. But in real life, there is a bunch of overlap between AS and coronary disease. The journal JACC Interventions has published an observational study from a large Belgian referral center. First author Leonard Minton. This study included 600 patients who had TAVI between 2008 and 2020. The authors asked 2 questions. Did coronary disease and its complexity associate with worse outcomes with TAVI, and did fixing these lesions with PCI associate with better outcomes? The results were clear. First, yes, as CAD complexity increased, as measured by the syntax score, 5-year survival worsened in parallel with increased CV mortality. And secondly, neither PCI nor the completeness of revascularization associated with any better outcomes. Well, as I learned in the accompanying editorial, this is not the only piece of evidence suggesting dubious efficacy of PCI before TAVI. A meta-analysis, which I'll link to, in Journal of American Heart Association found no association of benefit and a potential signal of harm with PCI. And the activation RCT, yes, an RCT comparing PCI versus no PCI in patients who were to have TAVI, failed to reach non-inferiority for PCI. And mortality in that activation trial was numerically higher in the PCI arm, as were rates of bleeding. So how to deal with coronary disease in the presence of aortic stenosis is a huge issue. We're doing more TAVIs, lots more now. Yet many of these patients will present with coronary disease. Now, if they were referred to a surgeon, there'd be no problem. There would be bypassed. If they have TAVI, there will be a temptation to do PCI, but the data for that looks less than reassuring. Now, I don't have the right answer, but it's complex, right? You have to consider things like, what's the life expectancy of the patient? What's the coronary disease actually looks like? You have to consider bleeding risk because PCI is going to obviously increase bleeding because of the dual antiplatelet therapy, and whether or not the TAVI could impair future coronary access. What I worry about is that there's great enthusiasm for TAVI. It's new, it's cool, programs need numbers, patients want to avoid sternotomy. There's a huge therapeutic tailwinds here. But perhaps the surgeon's ability to care for both conditions ought not be forgotten. Okay, third topic is ESC 2022. I'm recording this in Barcelona, Spain. I'm here for the ESC. It's the first time it's been held in person in 2 years, and that's a good thing because the greatest value of medical meetings is to be with colleagues. I don't have a citation for that. Allow me just to know that fact. So this week, I'll discuss the trials presented on Friday, and next week on the podcast, I'll have more, and there are a lot of trials from ESC. So the first trial on Friday, the TIME trial is a pragmatic trial that randomized more than 21,000 patients who had high blood pressure. This was a UK trial. It compared nighttime dosing of blood pressure versus daytime dosing, and it had a very legitimate endpoint of MI, stroke, or vascular death. Now, you might be wondering why folks would spend the time and money to study such a thing. I mean, who cares what time of day one takes a long-acting medication? Well, it turns out that numerous trials have reported major reductions in outcomes simply by taking medicines at night. The HYGEIA trial stood out because it reported a stunning 42% reduction in heart outcomes with nighttime versus daytime dosing of medicines. But that trial has come under withering criticism. In fact, also interesting is that in the days before time was presented here at ESC, the International Society of Hypertension published a systematic review and consensus statement on the matter of nighttime dosing of blood pressure medicines. The European Society of Hypertension and the World Hypertension League have endorsed this document, and I'll link to it. Quote, 8 published outcome hypertension studies involved bedtime dosing of antihypertensive drugs, and all had major methodological and or other flaws and a high risk of bias in testing the impact of bedtime dosing compared to morning treatment. This is what the authors wrote in the abstract. Well, here were the time results. The primary endpoint occurred in 3.4% of participants in the evening dosing group and 3.7% in the morning dosing group, giving a hazard ratio of 0.95 that was not anywhere near close to statistical significance, no difference. The results did not vary in any pre-specified subgroup, so the conclusion is simple. Taking medication in the evening was not harmful, not beneficial. You can take your blood pressure medicines any time of day you like. My comments. Wow. We went from a 42% reduction of events in HYGEIA to none in time. This is remarkable. And as per the International Society of Hypertension document, there are actually 2 other ongoing RCTs asking the same question about nighttime dosing, so we'll learn more in the coming months to a year. Now, I want to point you to what I feel is a very, very important paper on large effect sizes. It's in JAMA, 2002, first author, Perea. They did a systematic review of Cochrane reviews looking at statistically significant, very large treatment effects of medical interventions when such effects were recorded in the first clinical trial. And they found 2 things. First, large treatment effects in initial trials were not rare. They occurred about 10% of all reviews. And when additional evidence is obtained, most of the very large treatment effects became much smaller, and many actually lose their nominal significance. So the time trial leaves us, I think, with 3 messages. First, patients can take their blood pressure tablets any time of day they want. Second, we should always be skeptical of large effect sizes. And third, scientific papers that might change clinical practice ought to have to submit source data for independent review. Okay, second trial is the polypill, SECURE trial. The SECURE trial is a European cardiac outcomes trial of a polypill. This was aspirin 100 milligrams, ramipril 2.5, 5, or 10, and atorvastatin either 20 or 40 milligrams versus standard care in about 2,500 older patients in Europe. SECURE was secondary prevention. Patients had a history of type 1 MI within the previous 6 months, and this is a super important aspect. Patients with plaque rupture are high risk, and medical therapy likely has the greatest absolute risk reduction in these higher risk patients. That is, if they take their pills. Polypills improve the adherence problem by decreasing pill burden and treatment complexity. And previous trials show that adherence associates with better outcomes, obviously. Now, the average age of patients in SECURE was older, 75 years old, and that will come up again. So here are the results. After 3 years of follow-up, the primary outcome event of CV death, MI, stroke, or urgent revascularization occurred in 9.5% of patients in the polypill group and 12.7% in the standard care. That 3.2% absolute risk reduction resulted in a hazard ratio of 0.76 or a 24% reduction. The confidence intervals range from a 39% reduction to a 4% reduction and were statistically significant at a p-value of 0.02. And the Kaplan-Meier curves separate early and they get wider over time. Now, good news for the polypill was that all of the heart outcomes, the CV death, the MI, the stroke, favored the polypill group. Only urgent revascularizations, the softer endpoint, were similar. And you like it when the hardest endpoint in the composite drives the benefit. This is unlike the sacubitril valsartan and SGLT2 story in heart failure with preserved ejection fraction, where in those trials the softer heart failure hospitalizations rather than CV death is what drove the potential results. Now, in addition, there were no variations among countries and there were no significant side effects. But there were caveats. Now, these are older patients post-plaque rupture, and there were no differences in overall death. And that, I think, speaks to the competing cause of mortality in patients in their mid-70s. I mean, you can reduce CV death, but it did not translate into gains in lifespan. Second caveat is that SECURE was an open-label trial. This could have led patients in the polypill arm to behave in a more heart-healthy way. Strengthening the argument for this is that A, there was only a small, less than 10% difference in compliance, and B, no significant differences between groups in blood pressure and cholesterol. Now, polypills work via their simplicity. Polypill improves compliance. Now, here the very modest improvement in adherence did not drive blood pressure or lipids. Then how exactly did the polypill reduce outcomes by a massive 24%? The authors point to the pleiotropic effects of statins and possibly higher rate of aspirin use in the polypill group. Or maybe. All in all, though, here's what I think. There were no safety issues in this trial. Taking lots of pills definitely increases the work of being a patient, and SECURE found a large effect size that was statistically robust. I've been skeptical of combining this many drugs in one pill, but I have to say my initial impression of SECURE is positive. Senior author Dr. Valentin Fuster made an important comment in the press conference. He said there was a great tension in medicine between simplicity and personalized medicine. I mean, personalized medicine has its virtues, but in the case of post-MI patients, the simplicity of the polypill may be the better philosophy. The third ESC trial, called the CAPLA trial. Now, CAPLA, as I wrote in my preview piece, which I will link to, might seem like a highly EP-centric trial. I mean, CAPLA enrolled patients with persistent AFib, a group who's known to have lower AF ablation success when compared to those with paroxysmal AFib. CAPLA then compared the standard approach to AFib ablation, which is PVI, to PVI plus isolation of the posterior wall of the left atrium. But note that I'm not highlighting CAPLA because it might inform a specific niche area of EP. That's important because this is a multi-center randomized trial, and that's the best way to get to the bottom of treatment efficacy and safety. I highlight CAPLA because there has been a strong contingent of key opinion leaders who have advocated for posterior wall isolation in persistent AFib. In other words, posterior wall add-on ablation has largely been an eminence-based recommendation. The data support this practice has always been weak. Plus, posterior wall isolation entails ablating even more in the back wall of the left atrium, and that's the area of the esophagus, and thermal injury to the esophagus can be deadly. These are the many reasons I've not adopted posterior wall isolation as a routine strategy. So CAPLA randomized about 340 patients with persistent AFib. These were drug-refractory first-time ablations, and AF had to be greater than 7 days and less than 3 years. Here are the results. The primary endpoint of freedom from AFib or atrial tachycardia off drugs at 12 months was the same in both groups. Hazard ratio 1.01. Kaplan-Meier curves superimposed, not a shred of difference. Procedure times were longer in the posterior wall arm. The Australian authors, led by the famous Melbourne group, write that, quote, these findings do not support the empiric inclusion of posterior wall isolation for persistent AFib ablation. Now, I would go further. I would say these findings support the power of the randomized trial to support evidence-based practice over eminence-based practice. This should infuse us with caution about single-center studies, observational studies, and eminence-based practice. Okay, ESC has much more to come, and here is a brief teaser as I've already gone on pretty long already. The big trial, and I think one of the most important trials coming out of ESC, is going to be the Dan-Caves trial. Here, Danish researchers have done an RCT of about 45,000 men on the island of Funen, which is one of the islands in Denmark. One group gets screening, the other group gets standard Danish care. And this is not Mickey Mouse screening. This is serious screening. They did CT scans to look for calcium in the coronaries and aneurysms, ABIs to look for peripheral artery disease, rhythm assessments looking for AFib, and blood tests for lipids and glucose. The primary endpoint is also serious. It's death or cardiac events. Authors will also do a cost-efficacy analysis if there is efficacy. I really await this trial. It's important because there's a heck of a lot of screening going on in the U.S. Okay, second big study is best case scenario for PCI. The revived BCIS trial, REVIVE trial, another UK trial, randomized about 700 patients who had ischemic cardiomyopathy, ejection fraction less than 35% due to multivessel CAD, to either PCI versus medical therapy. I say it's a best case scenario because you had patients with amenable anatomy, high levels of viability, and LV dysfunction. Now the thing is, modern day disease modifying medical therapy is quite good for both LV dysfunction and coronary disease. So we shall see. Another important trial called a post-PCI trial. They will study the strategy of doing routine surveillance testing with non-invasive stress tests in high-risk post-PCI patients. I mean, for my entire career, the strategy of post-revascularization stress testing has lined the pockets of cardiologists. There is no question in my mind that dualities of interest drove this low-value therapeutic fashion. Now, recently, mostly it's stopped, but more and more, PCI is being done on super high-risk patients. For instance, patients who have stents at their proximal bifurcation points in the left main. And perhaps these patients will benefit from looking more intensely post-procedure. I'm glad this idea is being tested in a trial, and if post-PCI fails to find benefit, this should completely shut down the practice of post-revascularization stress testing, period. Okay, another important trial will be DELIVER. The DELIVER trial of dapagliflozin in patients with heart failure and ejection fraction greater than 40%. We already know from a press release that DELIVER met its primary endpoint of CV death or heart failure hospitalizations. The key finding will be what drove the endpoint. Again, look at the breakdown of endpoints. Will DELIVER be like Emperor Preserve trial of dapagliflozin? That was a positive trial driven only by heart failure hospitalizations, which were then only a small fraction of total hospitalizations. I love the SGLT2 inhibitor class, but you really want a costly drug to move cardiovascular death, or you want the reduction in heart failure hospitalizations to be significant enough to reduce total hospitalizations. There's also going to be an ADVOR trial. ADVOR is a Belgian trial will test the old drug acetazolamide in its IV form, in addition to loop diuretics for the treatment of patients with decompensated heart failure. The primary endpoint is, quote, successful decongestion, defined as the absence of signs of volume overload in the first 3 days and without an indication for escalation of decongestive therapy. Now, acetazolamide, an inexpensive drug that aids acute heart failure therapy, would be a big advance because acute heart failure treatment is so common. An important limitation here to look for, the trial was designed before SGLT2 inhibitors were widely available, and if ADVOR is positive, the question will be how do the results translate to patients who are on SGLT2 inhibitors or indicated for SGLT2 inhibitors given their diuretic effect. Another important trial called the BOX trial, again from Copenhagen, they will test both blood pressure and oxygenation targets in comatose survivors of cardiac arrest. In the oxygen target study, it is a test of PaO2s of 69 to 75 versus 98 to 105, and in the blood pressure arm, it was a map of 63 versus 77. I love trials that test strategies, especially those that test less aggressive measures. If the lower oxygen and blood pressure targets lead to similar results, it's a big gain, right? Because, of course, it takes less supplemental oxygen and less pressors to achieve the same goal. Now, there's a lot more trials, but I'll close with the Invictus VKA trial. This is an RCT in rheumatic heart disease of 4,500 patients, and they're going to compare rivaroxaban with vitamin K antagonists, mostly warfarin, in patients with rheumatic heart disease and atrial fibrillation. Now, the current recommendations for patients with rheumatic heart disease is to take VKAs, but the problem is that the quality of anticoagulation in developing countries where the rheumatic heart disease is often poor. Rivaroxaban makes it easy once daily dosing. The trial is going to enroll from 23 countries in Africa, Asia, and South America. It's a non-inferiority trial, and I think this is a shining example of when non-inferiority should be used. You don't need rivaroxaban to be superior to VKA. If it is just as good, that is perfect because it offers a much easier way to anticoagulate. The primary outcome of Invictus also is perfect. Unlike some recent non-inferiority trials like PROG 17 for appendage occlusion and Praetorian for sub-Q ICDs, the Invictus authors studied thrombotic events only, stroke and systemic embolism, and they made the safety endpoint as a separate endpoint. And look, rheumatic heart disease is not common in North America or Western Europe, but worldwide it is a major issue, and I commend the authors and look forward to the results. So that's it for this week in cardiology. It's an exciting week here in Barcelona, Spain, and there'll be much more next week. And remember, if you like this podcast, it really, really helps us if you could give us a rating or write us even a 1 or 2 sentence review, as these sorts of things help others find us. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.